Good evening. My name is Dr. Paul Stanislaw, and thank you for joining me on this Thursday. It's the second Thursday of the month. This is for October 2022. Tonight's topic is brow lifts and upper eyelid blepharoplasties. Very commonly, patients will come in and they'll ask about their upper eyelids. It's pretty rare for people to come and say, I want a brow lift. Most people come and say, I just want my upper eyelids done. So tonight we're going to talk about how the upper eyelids and the brows are related and what the treatment options are for both of those. So we're going to start with the upper eyelids, okay? And the way I describe it is this, is that when we're young, our skin is like a rubber band. It'll stretch and contract. So if you think of the upper eyelid skin, when we're young, we close our eyes and that skin would stretch. And when we open our eyes, the skin would contract. It would maintain its shape like a rubber band. And as we get older, our skin loses its elasticity. So when you open your eyes, it doesn't contract anymore. It just folds up on itself like a Roman shade. Now, there's nothing in the world that's going to make your skin elastic again. There's no fancy cream. There's no fancy laser. There's no fancy machine. I don't care what anybody tells you. I, nor anyone else, can make your skin into a rubber band again. And so what do we do? So when we have extra eyelid skin, we have you close your eyes and I measure how much extra eyelid skin there is with your eyes closed. And that's all you can take out is the extra with your eyes closed. And what does that translate to? It means when you open up your eyes, there's still going to be a little bit of a fold there. If I was to measure it with your eyes open and take the entire fold out with your eyes open, you wouldn't be able to close your eyes. So it's always degrees of improvement. I'm never going to give you 20-year-old eyes because I can't change the elastic qualities of your upper eyelids. There are no medical therapies, there's no medical treatments, there's no non-surgical treatments for taking care of the upper eyelid skin. It's basically surgery. So the way that procedure goes is we do that in the office. It's under local anesthetic. So basically they're sitting up and I take little forceps and I sit there and I measure how much extra eyelid skin with little forceps with your eyes closed. I measure that 1,000 times and I go to this eye and I measure that 1,000 times. And I take a little marker and I draw out the incisions. And the incision basically falls from the corner of the eye out to the lateral aspect of the eye. Now, the important thing for the incision length, what people don't realize, is oftentimes their folds go out further and the incision has to go beyond the fold. So the length of the incision depends on the anatomy of the person and how far the fold goes out. But it falls right in the crease that's naturally there. That's where the incision lies. So once we have that all measured out, basically we'll lay you back and then you just keep your eyes closed and I'll start on one side and I'll inject a little numbing medication on the outside here and I will cheat that little numbing medication around all the way around here. So it's just injectable numbing medication. It'll make you numb. And then once you're numb, I'm going to, again, measure. And then I'm going to remove that extra eyelid skin. And then I'm going to put a little line of stitches in there. And the stitches are really, really tiny. And the smaller you put the stitches, the better the incision heals. And then once I'm done with that side, I go and I do the other side. So same thing, I inject numbing medication, measure it, and then I remove that skin and I do that. The numbing medication lasts for about an hour. And so it'll start to, this numbing medication will start to wear off near the end of the procedure. Again, when I do that procedure, you're wide awake. There's no sedation, there's no IVs, there's no pills that you're going to take. Basically, it's just the numbing medication. Afterwards, when the numbing medication starts to wear off, people will describe a little bit of a burning sensation at the incision site, and that's usually just for that. It's not usually; it's always for that first night. That's how long it lasts. And so I don't give any narcotics. Basically, for this procedure, I just use Tylenol, and that's all people need for the discomfort for the upper eyelid. The next morning, there is no discomfort. So it's very, very well tolerated. Now, I give you some antibiotics, take a little bit before the surgery and a little bit after the surgery. just the Tylenol, but you do put ointment like Aquaphor or Vaseline on this incision as long as the stitches are in place. The stitches are in place usually for about 5 to 7 days, and then we take the stitches out in the office. People always worry about stitches being removed, that there's going to be discomfort. There will be no discomfort taking the stitches out. It's nothing to worry about. It takes literally 5 minutes and we get the stitches out, so it's very, very quick. The post-operative period, besides the Tylenol for the first day, the antibiotics around the time of the surgery, and the Aquaphor, you're going to sleep with your head of bed elevated, not straight up, but just a little gentle incline to keep your head above the level of your heart. No bending when you're straining for the week while the stitches are in. You can bend over for a second to put your shoes on per se, but nothing prolonged head dependent. No sit-ups, no yoga, no Pilates. All this is to try to minimize the swelling, because when I operate here, it is going to swell. That's the way it happens. But the more you bend over, the more you're head dependent, the more swelling there's going to be. And the more swelling that there is, the longer it's going to take for that to resolve. So we're doing everything we can to minimize that swelling. So again, head of bed elevated a little bit, no bending with your straining. You do ice for the first 24 hours. Ice only works for the first 24 hours. After 24 hours, it really doesn't help with swelling. So it's just gentle ice packs for that day. And that's pretty much it. When I do this procedure here, this area always bruises. Okay, I could be as meticulous and make sure that there's no bleeding whatsoever and cauterize every little spot and have no bleeding. It still will bruise. So you have to figure the bruise is going to start here. It's going to work its way down. The bruising is, people always ask me, well, how much bruising is there going to be? Well, some people bruise a little, some people bruise a lot. Some people, the bruise goes away really quickly, and some people, the bruise can stick around for a while. It's really a bell curve, okay? So the vast majority of people, the bruising will resolve in about 10 days, 10 to 12 days, okay? You can put makeup on if it bruises down here, no problem. You can do that at any point, but you can't put makeup on my stitches. So when you can put makeup on up here is I'm gonna take the stitches out between 5 and 7 days, and I usually ask for about 3 days afterwards before you put makeup on up here. So plan a time when you can be bruised for that amount of time. And that's pretty much it for it's just a little bit of bruising and swelling. Now, when the stitches come out at 7 to 10 days, there's going to be like little lumps and bumps at the stitches suture site. Those little bumps will flatten out on their own over time. The reason that they occur is just the skin is so thin that every place where you put a little stitch, there's going to be a little tiny bump, and that will just have to flatten out. The procedure itself, someone asked how long the procedure is. The procedure is about an hour and a half, hour and 45 minutes. Sometimes it goes a little quicker, sometimes it takes longer, but the majority of the time is the measuring of the skin. It's actually not the procedure. It's one of those, the saying goes, measure twice, cut once. I measure 1,000 times, and that takes the majority of the time, and the procedure is actually the shorter period amount of the time, because we want to make sure that we take out as much as we can to make a difference, but we want to make sure that you're able to close your eyes. So getting back to this, the post-op, the stitches come out. It doesn't hurt to get them out. The incision could be a little red or pink. Again, that can be pink for, not even pink at all. It could be pink for a couple days. Everyone's a little bit different. There's nothing I can do to speed up the resolution of the pinkness, and there's nothing I can do to speed up the resolution of the little lumps and bumps. So we usually have the people follow up on the 5 to 7 day mark. We usually have you come back at 1 month and 3 months, and that's just to watch how everything heals and everything settles down. So that's an upper eyelid blepharoplasty. That's when you have extra eyelid skin that's up here. The procedure itself is really very, very well tolerated. And that's why people all ask for it. They're like, I just want my upper eyelids. I just want my upper eyelids done. And what they don't realize is that the extra eyelid skin here is related to what happens to the brow. So now we're going to talk about brow lifts, okay, and how they're related. So if you look closely, if I go here and I push down on my brow, it makes it look like there's more eyelid skin. And I lift up on my brow, that looks like there's less eyelid skin. So As this falls, okay, it makes it look like there's so much extra eyelid skin there, and it really isn't that much. So as we age, again, the skin loses its elasticity. So our forehead skin used to be like a nice tight rubber band. As we age, it gets to be like a stretched out rubber band. So the skin container itself is a little bit bigger than it ever was. The other thing that happens is we lose fat in our face. So we lose fat in our temples, we lose fat in our forehead, we lose fat in our cheeks. The fat of our face is metabolically different than the fat of our belly. The fat of our belly is always metabolically active. It always wants to grow. It always wants to get bigger. The fat of our face wants to atrophy as we get older. It's going to shrink. So as that shrinks, we have less volume there. And then what happens is the bones actually change. So if you think of osteoporosis, as we get older, we get shorter. That bone loss occurs in our facial skeleton. So if I showed you a skull of a 20-year-old, I showed you a skull of a 60-year-old, you'd be able to tell the difference between the two of them very easily. A 20-year-old, a lot more bone mass in the forehead and the orbital rims, a lot more bone mass in the cheeks and the jaw. Eye sockets of a 20-year-old, a little round sockets of a 60-year-old, are more egg-shaped. So as we age, our facial skeleton dissolves front to back, up and down, and side to side. So it's just involuting. It's what we call remodeling. So if you think about the bony rims, these are called the orbital rims. These are the superior orbital rims. They're like a shelf. They should have an arch to it, and they're pushing out the eyebrow. So as we age, we lose the fat and we lose the bone mass. So the bone is acting as a shelf holding up the eyebrow. As the bone dissolves back in, the eyebrow will drop. Okay, so it's stretched out skin container, less volume, this less bone, and this will sag. And you can tell that if you look at pictures of you when you were younger, or if you just look at children, children's foreheads are perfectly smooth. There's no contours, it's all a gentle highlight, there's no shadows. And as we get older, we'll start to see shadows up here and hollows, and it's that fat that acts as a blanket, that there's fat that's there that hides the muscles of our forehead. It hides the bone irregularities. So they have a nice smooth forehead because there's that layer of fat, and as we age, that fat dissolves, and all of a sudden it's shrink wrapping. You're seeing that skin, that muscle that's just stuck to the bone underneath. So when this sags, okay, we do have a non-surgical option, and we have and surgery. Okay, so the non-surgical option is with Botox or Dysport. So Botox, Dysport, they're neuromodulators, fancy term for an injection that stops the muscles from contracting. Incredibly safe. Botox and Dysport, it's like Coke and Pepsi. They basically are the same with just two different manufacturers. And what they do is you inject it into the muscle, and it stops the muscle from contracting. So there's a muscle that wraps around your eye, the orbicularis oculi muscle. And that muscle's job is a depressor muscle. It's pulling your eyebrow down, okay? The forehead muscles that give the wrinkles, the muscle that gives you the wrinkles that go across here, the frontalis muscle, is elevating. This muscle's lifting this up, okay? So these two muscles, the muscle that wraps around your eye is depressing, pulling your eyebrow down. The forehead muscle is lifting this up, and they're in tug of war. So in that game of tug of war, if you selectively weaken the depressor muscle, the elevator muscle is now unopposed, and it might pop your eyebrow up. People come in all the time and say, Botox lifts this, or Dysport lifts this. Botox and Dysport lift nothing. All they do is paralyze things. All they do is stop muscles from working. So we can weaken this muscle as much as we want and make it completely flaccid. We're dependent on how well this muscle works to lift this up. So in some patients, their muscles up here don't work very well. In some people, they're really, really, really heavy. So you can weaken this until the cows come home. It's not going to pop up. But what I tell people is that, and in some patients that I look at them and I'll say, don't even bother. It's not going to work. But for the majority of patients, there's a chance that it's going to help a little bit. And the way I describe it is this. All you have to lose is your money. Okay, I can put some little bit of Botox in there. The risk is I bruise you, right? Then I give you a little bruise. All right, it's a bruise. You'll get over it. But if this works, okay, it is super, super safe. It's very little downtime, okay? You do this, in 3 days, the Dysport will kick in, and this will be up. And so what I tell people is we can do this for a small monetary amount, and your homework is to pay attention and to see if this works. And I usually see people back around 2 weeks afterwards to look at it. But if they come back and they say, you know what, the world seems brighter. I feel that this is up, it's really natural, I love it, this is great, then it has value and it's worth doing. If you come back in 2 weeks and you're like, you know what, I didn't see a difference, it just didn't work. All right, so you lost your money, but now you know the only other thing that you can do now is surgery, which now has downtime, it has more risks associated with it. Very minor, but there's still always risks. So that is how I non-surgically do a brow lift. There's one other way to do a brow lift with Botox, and I don't like doing it, and I don't like how it looks, and I'm going to describe it. So there's people that will inject Botox into the center of the forehead. All right, so they'll inject it right through here, and they'll weaken this area. And when they weaken this, it's going to drop the eyebrows down. Okay, when it drops the eyebrows down, by relationship, it's going to make like this is going to look higher because this is down further than this. The next thing that happens is because this is saggy and hanging, you feel subconsciously, you feel heavy. So what do you try to do? You try to raise up your eyebrows to do your own compensatory brow lift to raise up your eyebrows. Okay. When that happens, this part's quiet, but this part of the muscle is still intact, and these muscles will contract. And what that does is it makes this wrinkly up here and here. It's quiet in the center, which looks odd. And the way it jacks this up, it makes it very pointy. So it looks like Spock. So that's a very common way of trying to do a brow lift with Botox or Dysport. I don't do it that way. I think that looks really artificial. I think it looks really, really fake. But people do it. I would advise you to stay away from doing that. So I'm going to digress a little bit because I skipped a couple things. First, I'm going to talk about brow shape and brow stuff, which I should have started right in the beginning of this. But for women, the brow should have an arch. The highest part of the arch should be over the lateral aspect of the eye, and the eyebrow should be above the bony rim. For a man, the eyebrow should be flat with no arch at the bony rim. Okay, so that's what we call a sexual dimorphism. A man's eyebrow is different than a woman's eyebrow. So the goal for a woman's eyebrow is just to have it a little arch over the lateral aspect. Now, people will always, brow lifts are really a controversial subject because the people look at movie stars and they'll see that these movie stars or famous people, their eyebrows are really freaking high or weird or just looking abnormal. You have to realize that with a brow lift, the goal is not to raise the middle part, okay? Because if you raise the middle part, you look surprised. The goal of a brow lift is only to address the lateral aspect of the brow. So we call this lateral brow ptosis or lateral brow hooding. And as we age, this sags down. So the goal is to recreate, for a woman, the same natural arch. We want to have the eyebrow arch over the lateral aspect of the eye, and we want the eyebrow to be above the bony rim. That's the goal. For a man, it's completely different. If I gave that to a man, if I gave them an arch and raised it above their bony rim, I now have feminized them, and now they're going to look more feminine. There's some people that want that. Becoming a much more popular procedure in the recent couple years with the transgender surgeries and stuff like that. So if a man wants to look like more feminine, we can do a brow lift to feminize them. But most men, when they want to do a brow lift, they're afraid of that. They don't want to do that. So for a man, the goal is just to keep the eyebrow flat and at the bony rim. So that's the normal anatomy of a brow. Okay, and that's what we're trying to achieve. We're not trying to make people look surprised or look odd. And again, For men, it's a very fine line. If we want to feminize them, we do one thing. If we want to keep them looking male, we have specific goals. We don't do a woman's brow lift on a man that wants to say we don't want to feminize. The other thing, which I didn't talk about, is that people will come in all the time and they will want Botox to their forehead. They hate these wrinkles that are embedded here, okay? And not everyone's a candidate for doing Botox to their forehead. So these people will come in and have all these deep wrinkles, and their brows are like, what they're doing is their compensatory brow lift. They're using their frontalis muscle, their forehead muscle, to raise up their eyebrows so that they can see. If you Botox them, if you weaken this muscle, and they say, oh, I hate my wrinkles here, I want Botox here. If you weaken them just the smallest bit, you're taking away their compensatory mechanism, their own compensatory brow lift. They can't lift it up, and they're going to drop, and they're going to feel heavy. So not everyone is a candidate for Botox for their forehead because they're doing their own brow lift with their forehead muscles. So that brings me to the next point. So a lot of times people are walking around with this all wrinkly all the time, and their brows are up. And we'll take their pre-op photographs, and we'll show them, where their eyebrows are, and they have all these wrinkles across their forehead. When we take their post-op photographs, we really don't want their eyebrow higher than it was before. So they might say, oh, look, my eyebrows are in the same position as they were before. But if you look closely at the photograph, you'll see that they're not using their forehead muscles anymore. Their forehead is smooth now, okay, because they're not like this the entire time. You're lifting it up, but you're not going artificially high. You're going to where it normally should live, where they were doing it, but now they're not using their forehead. They're not having the wrinkles here. So the goal of the brow lift is a very subtle thing. It's very natural looking. It's just to try to lift the lateral aspect up, not to do this. It's not to be distracting. It's not to change the way someone looks. It's just to make them look brighter, more awake, and less sleepy. Okay, because people all the time will say, oh, you look awfully tired. And you're like, I don't feel tired. But it's because they're interpreting this saggy as you being tired. And that actually goes back to the muscles lifting. So if you're using your forehead muscles all the time, right, from the time you wake up, and at the end of the day, these muscles start to fatigue. They can't lift up your brow anymore. They've been working all day long raising it up. And so as these muscles fatigue, this will start to sag, and that's why you look more tired at the end of the day. So that's brows, and that's what happens. So you lose the bone mass, you lose the fat, these sag. And we use the forehead muscles to compensate for it. And the one option is to do the Botox here as a medical option. Again, doesn't work for everybody, but it's a very safe thing to try at least once. And your homework, like I said, is to pay attention. If it doesn't work, then it becomes a surgical thing. All right. And so the surgery for here is called either a brow lift or a forehead lift. Those two things are interchangeable. Brow, forehead is the same thing. People will come in all the time and say, I want a full facelift or I don't want a full facelift. Okay. Full facelift is not a surgical term. All right. A forehead lift, a brow lift addresses this part. An upper blepharoplasty addresses the skin like we talked about. A lower blepharoplasty addresses the fat underneath the eye. There's a mid facelift, which sucks. Don't bother doing it. It's not a good procedure. And then there's a facelift. The facelift addresses the lower third of the face here. Jowls, marionette lines, jawline. And then there's a neck lift. Okay. When I talk about a facelift, the facelift includes the neck lift, face and neck lift. But a brow lift is by itself, right? So it can be combined with the facelift. It can be combined with the upper eyelid or lower eyelid. But if you're just talking about your brows, it's a forehead lift or brow lift. Now, the next thing that's confusing with brow lifts is that there's 20 different ways of doing a brow lift. And it depends on a lot of factors. It depends on people's hairlines. It depends on if it's a man or if it's a woman. It depends on how deep the wrinkles are. Okay, so we'll talk about these different types of brow lifts. So there is what's called, I'm going to talk about this, but you don't ever want to do this. There's what's called a direct brow lift. A direct brow lift is when people make the incision right above the eyebrow, right here. Cut that up, lift that up. It always heals horribly. The incision never hides well. It always looks ridiculous. Don't ever do a direct brow lift, okay? Now, for men, usually men, like myself, will have deep wrinkles embedded into our forehead. So that sometimes we'll do a mid-forehead lift. So I might have one wrinkle here and one wrinkle here. And so I'll put the incision into, and this can be done under local anesthetic, because this is a very simple procedure. If you have deep wrinkles, you can put the incision in one wrinkle, excise the skin, and lift it up. And now remember, for a man, I want to keep this at the orbital rim, and I want to keep this flat. So I can lift this up. I'm going to make this incision right here, and I can make this flat and not arch it. For the other side, what we'll normally do is stair step it. We'll put the incision in a wrinkle that's a little bit higher so it doesn't match, and put it right in the incision and lift that up. So mid-forehead lifts are good for men, but most women don't have wrinkles deep enough to do that. Some do, but it's pretty rare. So that's a mid-forehead lift. All you're doing is excising the skin. You're lifting the skin up, nice, and then putting stitches in. Again, stitches are in for a week in that situation. After the stitches come out, the incision is going to be a little red. Might be a little lumpy bumpy, but that's usually not an issue with this type of skin. But when I do it, I'll usually put glue and tape on that incision after the stitches come out, and that will stay on for another week. So we're trying to do everything we can to make that incision heal as nicely as we can. So stitches for a week, glue and tape for a week. Again, discomfort's minimal. Procedure's done in the office with just local anesthetic. In that situation, you can drive yourself home and drive yourself there and drive yourself home. Really not an issue. I forgot to talk about the upper lid bleph. I'm gonna digress again. When I do the upper lid bleph, even though there's just local, there's no anesthesia, there's no IVs, there's no nothing, I still want someone to drive you home from the procedure. And the reason being, and it's never been an issue, but it's just my rule, just in case this swells, say this area swells, and you're driving home and you get into a car accident because you didn't see someone drive through the intersection. So whenever I do an upper eyelid blepharoplasty, you need to have someone drive you home, okay? And it's not because of sedation or anything. Again, it's just because, God forbid, that this is swollen and you can't really see well and you get into a car accident driving home. So getting back to the brow lift. So we talked about a mid-forehead lift that you can drive yourself there, drive yourself home, stitches for a week, glue and tape for another week. There is going to be some numbness above that incision, all right? And those nerves will grow back. There's no way to do that surgery without that happening. But the nerves that give you sensation to your forehead come out of your eye sockets and they come up over your forehead. And so if you make a cut in the skin here, it's not unusual for it to be a little numb above that. And over a couple months, those nerves will grow back and that will go away. Then there's what's called a pretracheal brow lift, where you can make an incision right in front or right at a tracheal, right at the hairline. So that's more likely done for women because they don't have the wrinkles here. So you'll make an incision around here. You'll lift up the skin, and that again can be done many different ways, different levels. But essentially you're making an incision here and you're taking this skin and you're lifting this up, again, addressing the lateral hooding, giving a natural arch for a woman, flat for a man. But for a woman, you want to raise that up above the eyebrow, above the orbital rim, and you have that same incision that goes right along that hairline. That incision hides very, very well. Again, the stitches are in for a week. Really can't put glue and tape up there because of the hair, but you can pull your hair down and you can hide it. The thing that I want to tell you, though, in that situation, oftentimes it can be a little swollen right around here, and that can take a couple weeks for the swelling to go down, so you might have to pull your hair down after that procedure. Again, there's going to be some numbness above that incision. Again, that will resolve with time. That can be done in the office with local anesthetic once again. You don't need someone to drive you there or home because, again, the swelling's up here, not really down here. For all these procedures, there is always going to be some swelling up here. And because it's on top of a hard bone, what you have to realize is when we're doing a brow lift, we're going to try to overcompensate a little bit by like 5 millimeters. So what I tell people always before having a brow lift is don't be alarmed. It's going to be higher than you think it should be. We're going to do 5 millimeters, okay, a little bit higher. And what's going to happen, and the reason that happens is as this swells on top of a hard round bone, it's going to be higher. And then when the swelling goes down, it's going to deflate and it's going to fall, okay? It's always going to fall. So we're trying to keep the swelling to a minimum. We're trying to elevate a little bit higher because we're going to compensate for that. I tell patients all the time, because they all come in with the same concern. When you start talking about brow lift, they say, oh my God, I don't want a brow lift. I don't want to look like this person or that person. They just think of all the bad examples of famous people. And I tell people, I have never made someone look surprised. I have never made them look arched or scary or weird or changed them. Ever, ever, ever. I don't worry about that at all. What I worry about is things falling and settling, okay? That this is a very subtle thing. It's a game of like a couple millimeters, right? So the eyebrow is supposed to move all the time, right? I'm surprised, I'm mad. It's showing expression, it's moving. Where is it supposed to be, right? What is that answer? Is it supposed to be here? Is it supposed to be here? It's only to be a subtle thing and lift this up, okay? But that's just a game of millimeters. So what I always worry about is it settles too much, all right? If it settles too much, guess what? I got to do it again, all right? And over my 22 years, I've had to do it over again a couple times, okay? It happens. But I've never made someone look surprised, okay? So for the brow lift, again, it's a pretracheal or right at the hairline incision that hides very, very well. There's another way called an endoscopic approach brow lift. An endoscopic approach brow lift is when we make incisions up in the hairline. So we'll make an incision right here. We'll make an incision here. Now, what's the beauty of this is that these incisions are smaller. When you're doing the pretracheal incision, it has to be longer because you're shifting this up. You're removing eyelids, forehead skin. So you're cutting that out. So the incision tends to be longer. For the endoscopic approach brow lift, you're making these very small incisions. Yes, you did miss the upper eyelid discussion. Sorry about that. So someone just asked if they missed the upper eyelid discussion, and we did that in the very, very beginning. So we'll try to circle back to that. So for the endoscopic approach brow lift, little incision here, sometimes a little incision in the center. Now for this procedure, it's a little bit different. So in this procedure, you're getting down to the bone. So you're on the skull and you're getting down, you're freeing up all the tissue that's out here laterally and you're lifting that up. So you're lifting this, you're freeing it off the bone all through this area and you're just shifting it. So you're just taking that forehead skin and you're shifting it back. You're not cutting anything out. All you're doing is freeing it up from its attachment below, shifting it up. And then you're putting sutures in up here to anchor it in its new position. The beauty of that is that the incisions are much smaller. They're up in the hairline. They hide very, 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 very well. Less numbness because you're not making those bigger incisions. You're not cutting the nerves as they come up. There's going to be some numbness in some little areas, but much less numbness. So there's a little incision here, potential little incision there. And you're freeing that up and you're moving it and you're using sutures to anchor it in its new position. And studies have shown that it takes about 4 weeks to heal down in its new position. And so we use these sutures. I usually use sutures that dissolve and they'll go away over time. But those sutures are just to hold it until it heals in its place. Again, a little bit of an overcorrection because I know it's going to fall with the swelling as the swelling goes down. So we're going to shoot for 5 millimeters. Again, we're just trying to lift in this superior lateral vector. We're just trying to lift this way. We're not lifting straight up, and we're not lifting the middle section there. The endoscopic approach brow lift, because it's on top of bone, that procedure is sort of a 50-50. Sometimes I'll do it in the office, and sometimes I'll do it at the hospital. The difference here is this, is that I can inject numbing medication and numb you up completely for the endoscopic approach brow lift. That's not the problem. The problem is that because I'm on top of the bone, you hear me scraping. You hear me going scrape, 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 scrape. Not everybody's cool with that, okay? Some patients like, yeah, I don't care if I hear it. I don't want to go to the hospital. I don't want to go to sleep. I don't want to have anesthesia. I don't like anesthesia. It makes me feel. I just want to get this done, and I'm cool with the sound. There's other people where they don't like needles. The sound is going to wig them out. Those people I'm taking to the hospital. I'm putting them to sleep. All right, so same procedure, same outcomes, same local, when you're awake, when you're asleep. Okay, going home the same day, no one's staying over, regardless. Sound is, it's the way I describe it is you're at the dentist and the person next to you is getting drilled and you can hear them getting drilled. Doesn't hurt you at all, but hearing that drill, you're like, oh, I hate that. That's what it's like. You're not going to feel anything, but you're going to hear it, and not everybody's cool with that. So, so it's sort of 50-50. I'll take some people do it in the office, and some people I'll do at the hospital. So that's going in through here and through here. So that's an endoscopic approach brow lift. And then there's another, what we call bicoronal or a modified, where they make an incision all the way through here and through here. And that's kind of really old schoolish. You're making this large incision that goes from here to here, and you're actually lifting everything off. You're on top of the bone, you're lifting it off, and then you're pulling that up, and then you're anchoring, you're cutting out extra skin, and you're sewing that tight. That surgery tends to make people number a lot more because of the length of the incision, and it makes them more numb behind the incision, and it stays numb for longer, and sometimes it doesn't all the way come back. They also have much bigger scars, and they tend to have much greater hair loss because they're pulling on the incision to give the lift, and when you pull on the incision, it gives you more hair loss through there. So it's a much bigger procedure. I don't think it has any real benefits. I think the post-operative period's longer, and I think the scar is greater and the numbness is greater. I will tell you that people have different value sets. That people will say, oh, you know what? As long as it works, I don't care if I have a big scar, or I don't care if I have hair loss. I am not of that value set. I don't think having raised brows at the cost of having a big scar and being numb and having hair loss there is a good trade-off. I don't believe that. I think that's, it goes against everything that I believe in. So my goal is, and again, some patients might say, I don't care. I don't care if I have a big scar, as long as it works. I want to do it well and not have a big scar or have a lot of hair loss. So I don't do that procedure. I'm not a big fan of that procedure. I think that the downtime, the hair loss, the numbness is just too great of a price to pay for having your brows up. So I do it. Someone just asked if we're going to post this, and yes, we are going to post this. This will be on our website, which is stanislawmd.com. It's going to be on our Instagram page, and it should be on our Facebook page. And it should be on YouTube at some point. So it'll be on all of those places. So the whole thing will be posted, so if you can go back. So those are the different types of brow lifts, and there's a lot of different versions of it. Having said that, even with all those different procedures, there's very many nuances that go into that procedure. They're not all the same. So 5 surgeons can do endoscopic approach brow lifts and to make these little incisions, and you have 5 different incisions, 5 different outcomes. So the way I describe it is there's a baking show on Netflix, and I don't know if people watch Netflix or this baking show, but they'll have 12 different contestants. And of those 12 contestants, there's going to be a challenge. And all of those people have the same ingredients, the same amount of time, and the exact same instructions. With everything the same, you'll have 12 different outcomes, okay? The same ingredients, same instructions, same everything, 12 different outcomes. So it's the same really with plastic surgery, okay? You could have everyone doing the same brow lift, exact same brow lift, and have completely different outcomes because of the little nuances, how the vector is, how it's lifted, how it's sewn, how it's elevated. So there are a lot of nuances to that. In my practice, I do mostly endoscopic approach brow lifts. Sometimes I'll do pretracheal brow lifts. For men, I generally do the mid-forehead brow lift. So those are all the different ways. Now, usually, you know, when I look at people in the office, assessing them, evaluating them, I'm feeling them, I'm all right, how much brow is it and how much extra eyelid skin is there? Okay, because it's a combination of the two. Sometimes it's just all brow. Sometimes the brow is fine, it's all upper eyelid. But most people, it's a combination of the two. It's a little bit of upper eyelid, it's a little bit of the brow. So this is one situation where it's really important to understand the different procedures. Because people will come in and say, I just want to do the upper eyelid. But I will show them photographs of patients that I've done where I've just done the upper eyelid, where I've just done brow, and where I've done the combination of the two. So a brow lift raises this up. So the subunit here, all right, as we age, this deflates. I talked about the fat loss, the bone loss. This falls down, it gets shorter, and this gets lateral hooding. So I spend a lot of time during the consult talking about, well, what part is it that you see? Is it the extra eyelid skin that you see? Or is it the brow that you see? Okay, because they are intimately related. So is it the brow ptosis, extra eyelid skin, or do you see both? So patients almost inherently will say, well, God, I don't want to do a brow lift. That sounds like much more than I want. I just want to do the upper eyelid. So let's just do the upper eyelid. But the upper eyelid, when you cut this out, it doesn't lift this up. If anything, it pulls it down. So say I talk about a brow lift, I talk about an upper eyelid, and they say, you know what, I don't want to do a brow lift. I just want to do the upper eyelid. Well, I go and I remove as much eyelid skin as I can so that they can still close their eyes, and I do all of that. I cut all that extra out. They come back post-operatively, 3 months, 6 months. They're like, yeah, doc, that's healed up well, that looks good. But you know what? I still see this brow ptosis. This brow is still hanging down. I want to do a brow lift now. Well, the problem is I will have removed so much eyelid skin here that if you try to do a brow lift afterwards, you're not going to be able to close your eye. So this is a situation where your decision burns a bridge. So if you do the upper eyelid first, and then you realize afterwards, oh, you know what? It's really the brow that I saw, not the eyelid skin. I want to do the brow lift now. So much eyelid skin will be removed. You won't be able to do that afterwards, okay? Now, eventually, over the years, you're going to lose more bone mass, lose more fat, skin's going to sag more, and you'll probably be able to do a brow lift down the road, but you won't be able to do one right afterwards, okay? So again, I spend a lot of time trying to educate people into what is it they see. We all see things differently. I could show you 2 identical pictures, black and white pictures, same dots, everything the same. One person sees one thing and one person sees something else. All right. So when we're looking at that brow, I really have to educate people into, is it just the eyelid skin? Is it the brow? What is it that you see? because we're trying to pick the right procedure for the person, because not everybody wants to do a brow lift. Not everybody needs a brow. Oh, I shouldn't say need. Nobody needs any of these surgeries, except, all right, we'll get into that in a second. But the brow lift, okay, does this, upper eyelid does that. So you have to decide what is it that you see and what's the important thing. I can't stress that enough. And during the consultation, I'll show people pictures on my computer and I'll say, all right, so this is a person who's got very deep set eyes. I talk about a brow lift, I talk about an upper eyelid blepharoplasty to them, and they say to me, you know what, I don't want a brow lift. I just want to be able to put my makeup on without having to do this. Not interested in brow lift. I just do the upper eyelid blepharoplasty, and it works out beautifully because they have deep set eyes. It works great. You don't see the hooding, it's just great. I show them another picture of a woman with different eye anatomy, different brows, different eyes that are more forward. And I tell them that I went through the whole consult with this patient. I talked about brow lift and upper lid bleph. They didn't want to do the brow lift. They just wanted to do the upper lid bleph. Now that patient was happy. They let me show their photographs, but you'll see that there's still a hooding here. They do the incision, there's still hooding. And some patients, when I look at showing this pictures, I'm like, well, what is it do you see? Do you see more eyelid skin and you think it looks good? Or, you know what, the eyelid skin's good, but they still see the hooding. If the patient looks at the pictures and say, you know what, that looks good to me, then it's just an upper lid bleph. If they look at that picture and say, oh, you know what, it's really, I still see that hooding, that brow. Well, that's, when I show them that picture and they say that, then I tell them, listen, that's the part that you see. You really need to do a brow lift. That's that's the correct treatment for you because that's the component that you see. Again, I don't have the pictures to show right now, but during the consultation, I go over the different anatomy types, deep set eyes, more forward eyes, how that changes the results of a brow lift of an upper lid blepharoplasty. And it's not, everyone's different. Everyone's anatomy is different, how they heal is different, and the results are often different depending on the anatomy, and the decision for the procedure will depend on the person's anatomy and how they visualize the aging process. I touched on the word need. Again, I deal in the cosmetic world. All I do is cosmetic, upper lid blephs, brow lifts, cosmetic procedures. I don't do anything insurance at all. Insurance does not pay for brow lifts. However, if your upper eyelid skin is so hangy, there's so much extra eyelid skin that it's covering your eyes and it's blocking your vision. So that's called visual field defects. So in some patients, there's so much skin, it blocks their vision. That can sometimes be covered by insurance. So in that situation, if I have a patient who comes to me and I'm looking, I'm like, oh my God, the skin is so heavy, insurance should pay for that. I will send them to an oculoplastic surgeon or another surgeon that does insurance stuff. And I usually use oculoplastic surgeons for this procedure because they can do the visual fields test. They can test that, document how much vision is being lost. Then they can submit it to the insurance company with photos and all that other documentation. And the insurance company will say, yay, nay, we'll cover it, we won't cover it. That's gotten much, much harder in the years. Over the years, it's gotten so difficult to get insurance to cover things. And I will have patients where I will swear, my God, this has got to be covered. This has got to be covered. And I'll send it to the oculoplastic surgeon and have them do all the tests and stuff, and insurance still says no. So it's gotten really, really hard to get that covered under insurance. But that would be one indication where I'd say, yes, there is a need. That skin is blocking their vision. There is a need for a medical necessity for that, and that should be covered by insurance. But from my standpoint, brows are not insurance. There's no need for a brow lift. It's a benefit issue. You may benefit, you might not benefit. And again, I deal in the cosmetic world. I don't deal with insurance for that stuff, but sometimes that is covered for that. But those two procedures are intimately related. I hope I didn't confuse people. It is a confusing subject. It is a little bit easier to go in consultation because I can show you in person and point out the different things, and I can show you pictures of patients who have allowed me to show their pictures, and I can show them the different surgical outcomes. It's not something that I can digitally image. Like some things we can image, like a neck or a nose, and I can do it like Pixar and make it all different. For upper lid blephs and brow lifts, there are so many variations in the anatomy that there's no way to accurately predict what you're gonna get with the upper lid blepharoplasty. So it'd be very misleading for me to image you and say, oh, now your brow's up and now your brow's down. It's really tough to predict that. There's a question. Oh, there's just an answer. So that is really brow lifts, upper lid blephs, how they're related. Brow lifts can be done in the office with just local or at the hospital asleep. Upper eyelids, I can do, in the 22 years I've been doing this, I have had one patient where I took them to the operating and put them to sleep just for the upper eyelid blepharoplasty. One person that I had done that. There's one person that was so nervous that I should have done that for. And everybody else in the 22 years I've done in the office with just local. I have had patients, and this is the crazy thing, I've had multiple patients when I'm doing the upper eyelid blepharoplasty in the office, awake, fall asleep, sound asleep while I'm doing the surgery. That actually happens much more often than you would ever imagine. And to me, it's kind of like, just to think about it, like how could someone fall asleep while I'm operating on their upper eyelid with local anesthetic? It happens all the time. So once I've got you numb, it's actually really very easy. The numbing medication is actually very easy. So it's a very easy procedure. Again, very simple. And that's why a lot of people will gravitate and they'll ask for just the upper lid blepharoplasty. But again, you got to make sure it's not this part that you see. Are there any questions about anything? Again, we're live. If you have any questions that I confuse you about anything, I can try to answer those questions. Again, we're doing these live talks the second Thursday of the month. Wait, is there a question? Hang on. Ooh, of course you're gonna ask me about cost. All right, so I'm not gonna go into cost. It makes me sound like a used car salesman, and I don't like sounding like a used car salesman. The thing about fees is that it varies a lot from physician to physician for sure. So that there's a huge range for that. But even within a practice, people have different, it's based on time. And some people have more work that I need to do and it takes longer. And there's some people where it's a lot less work that I need to do and it's shorter. So the fee amount is quoted at the time of the consultation. So people come in and we go over the consultation, and from my standpoint, there's never ever any pressure during a consultation. Like people get nervous about consultations. And I'm like, there's nothing to be nervous about a consultation. All we're doing is talking. I'm not here to talk you in. Like my job is not to sell you anything. I don't care if you do it. I don't care if you don't do it. What I care about is people understand the procedures. I care that they understand what the expectations are, the risks, the benefits. I'm all about educating people and understanding that. So I go over all that stuff with you during the consultation. At the very end of the consultation, one of my staff members gives you a quote. If it's at the hospital, the quote includes the OR fee, the anesthesia fee, and the surgical fee. If I'm just doing something in the office, it's just my fee, it's just a surgical fee. They go over all of that with you, and you come out with that piece of paper, and that quote's good for a year. But there's never any pressure, so it's not like we like try to force you into doing something. So I don't like to answer questions about money, again, because it just makes me seem cheesy. Any other questions besides money questions? I guess not. All right. I don't know what the topic is for next, the November topic. Again, it'll be the second Thursday of the month. we'll post that what the topic is. Again, if people have any specific questions, just email us. The website's stanislawmd.com. The email is info@stanislawmd.com. The office number is 860-409-1515. So if there's any ever questions, just call us and we can try to answer them over the phone or via email. If you guys have any topics that you want me to discuss, please email them into us and I try to discuss your questions. And I think we are like 5 minutes early. I try to just keep it at an hour. Again, is there any questions about brow lifts or upper lid blephs? And there really isn't. All right. So thank you all for joining me for this evening. Try to tell your friends, if this is, if you feel that this is helpful. Again, I try to make these completely educational. I'm not here to sell anything. I'm telling you and again, these things are my opinions. Take them for what they're worth. I tell people you should always get multiple opinions. But again, my job is to tell you what I think is value, what doesn't have value, what I think works, what doesn't work. And my job is to keep people out of trouble. All right. Thank you again for joining us and have a great night.